Thank you, Professor K. Carr, and welcome to all of our colleagues here at ESC. I'll talk about the impact of comorbidities on outcomes in the first 3 cohorts of Garfield AF. Here are my disclosures. Moderate to severe chronic kidney disease, myocardial infarction in an age greater than 80 years are high-risk comorbidities in patients both with and without atrial fibrillation. In Garfield AF, we sought to quantify the impact of incremental risk of these 3 comorbidities in 28,624 patients who were enrolled. And we examined 4 clinical outcomes: stroke and systemic embolism, major bleeding, all-cause mortality, and cardiovascular mortality. We defined moderate to severe chronic kidney disease as stage 3 or greater kidney disease. Stage 3 chronic kidney disease is a moderate reduction in the glomerular filtration rate, GFR, ranging from 30 to 59 ml per meter squared. We define no chronic kidney disease or mild chronic kidney disease as stage 1 or 2 with a GFR of 60 or greater units. The reference group included patients with no or mild or unknown chronic kidney disease. Here are the baseline characteristics. We examined 28,624 patients. Their mean age at the time of diagnosis of atrial fibrillation was 69.7 years. 2,969 had moderate to severe chronic kidney disease. 2,872 had prior myocardial infarction. 4,867 were greater than 80 years of age. The major races represented in Garfield AF are Caucasian, non-Chinese Asian, and Hispanic Latino. The mean body mass index was 27.8 kilograms per meter squared. So by definition, on average, this was an overweight cohort of patients. Here we have the adverse clinical outcomes according to comorbidity in Garfield AF with 1-year follow-up. And these are the crude data that are presented. The overall population had a stroke rate of 1.3%. So that's the incidence in 1 year. And all of these are incidence rates in 1 year. Chronic kidney disease, 2.2% had stroke. So chronic kidney disease had the most stroke with these raw data. Myocardial infarction, the stroke rate was 1.6%, and the very elderly, stroke rate 2.1%. For major bleeding in the total cohort, a 0.8% incidence in the first year. Chronic kidney disease had the highest major bleeding rate, 1.8%, MI 1.2%, and the very elderly 1.4%. For all-cause mortality in the total population, a 4.0% incidence in the first year. Chronic kidney disease, once again, very high all-cause mortality rate of 9.4%, just about the same as the very elderly, 9.6%, and the patients with MI as a comorbidity, 6.9%. And for cardiovascular mortality in the overall population, 1.7% incidence. For chronic kidney disease, these patients had the highest cardiovascular mortality rate of 4.3%, MI patients 3.9%, and the very elderly 3.8%. Hazard ratios for adverse outcomes were estimated using a Cox proportional hazards model and adjusted for components of age, sex, race, and smoking. And cases without the selected comorbidity were used as the reference for each of the subgroups. Here you see graphically presented the adjusted hazard ratios for patients with chronic kidney disease, and this shows a greater risk of adverse outcomes than in the general Garfield AF population. Stroke, 60% higher than the overall Garfield cohort. Major bleeding, more than double. All-cause mortality, more than double. And cardiovascular mortality, 2.3 times higher in these adjusted values compared with the overall Garfield cohort. Now we come next to the adjusted hazard ratios for patients with myocardial infarction as comorbidity. And for stroke, the MI patients had a 40% greater stroke rate, a 40% greater major bleeding rate, a 69% greater all-cause mortality rate, and as you'd expect in patients who've suffered myocardial infarction, their cardiovascular mortality rate was 2.5 times greater than the overall Garfield cohort. In the very elderly, those greater than 80 years of age, their stroke rate, when adjusted, was 85% greater than the total cohort. A major bleeding rate was 94% greater. The all-cause mortality rate was 3.5 times higher, and the cardiovascular mortality rate 2.9 times higher. Now we look at the anticoagulation and antiplatelet therapy regimens that were prescribed both for the total population and for each of the three comorbidities that we examined. And if we just sort of look at this with a bird's eye point of view, the light blue represents warfarin. The red and the orange combined represent the novel oral anticoagulants, the NOACs. The green represents antiplatelet therapy only, and the purple means neither antiplatelet therapy nor anticoagulants. So the overall anticoagulation represented by the bottom three bars is over 60%, and then there are about 10% of the patients receiving neither antiplatelet therapy nor anticoagulants, and the remainder in green are receiving antiplatelet therapy. Interestingly, in the group with chronic kidney disease, this is the group that has the most anticoagulation, and they also have the very high use of NOACs. The MI group has the lowest, relatively speaking, use of anticoagulants, and they have the highest use of antiplatelet therapy only, with only a sliver receiving neither antiplatelet therapy nor anticoagulants. Quite interesting is that those patients aged greater than 80 years have an anticoagulation and antiplatelet only profile that's very similar to the overall population. In summary, among 28,624 patients with one-year follow-up in Garfield AF, a large proportion suffered the comorbidities of chronic kidney disease, myocardial infarction, and had age greater than 80 years. These comorbidities increase the likelihood of stroke and systemic embolism, major bleeding, all-cause mortality, and cardiovascular mortality. The frequency of anticoagulation ranged from about 60% in those patients with myocardial infarction to almost 70% in patients with chronic kidney disease. These results suggest we should consider increasing the frequency of prescribing anticoagulants in AF patients with the comorbidities of chronic kidney disease, myocardial infarction, or age greater than 80 years.